Vaishak start it.
Okay, sir.
Okay, good morning, everybody. I am Dr. Purnima from General Medicine Department. So today we shall start with a case scenario. A 55-year-old IT professional came to the casualty with history of breathlessness for the past 5 days. He was taking paracetamol, Ritalin, and azithromycin for 3 days. From a nearby medical shop. Am I audible? Okay. On examination, he was tachypneic, febrile, BP was 110 by 60 millimeters of mercury. There was bilateral scattered crepitations, and pulse oximeter SpO2 was 88%. ECG showed sinus tachycardia. A chest X-ray was taken, which is like this. It showed bilateral opacity, scattered opacities, which is more on the mid and lobosomes. Okay, there is no cardiomegaly, no pleural effusion. So, what is your diagnosis? So, anybody? Okay, so we will discuss it in the later part of the class. So, in this scenario, nowadays it is the COVID-19 era. Everybody is discussing about acute respiratory distress syndrome. So, I thought that today's class, it would be better to have a knowledge about acute respiratory distress syndrome. So, in a nutshell, we will discuss what is the definition, etiology, clinical codes, and pathophysiology. We will discuss something about the investigations, differential diagnosis, and the management. The management, we will briefly go through the mechanical ventilation, fluid management, evidence-based recommendations. This class is based on Harrison's textbook. So if you have any doubt, you can go and refer that book. Okay. So coming to the definition, ARDS, it is defined as a clinical syndrome of severe dyspnea of rapid onset. And there will be
പ്രധാനമായി 3 നിറങ്ങളാണ് അതിലുള്ളത്. ചുവപ്പ്, മഞ്ഞ, പിന്നെ നീല. ഇത് ചുമ്മാ ഇട്ടതല്ല, ഇതിലും ഒരു അൽഗോരിതം അവർ ഉപയോഗിച്ചിട്ടുണ്ട്. എന്തായിരിക്കാം അത്? ഈ 3 നിറങ്ങളുടെയും ഇടയിൽ ഒരു പച്ച നിറം കാണുന്നില്ലേ? അതാണ് ഈ ലോഗോയുടെ ഏറ്റവും വലിയ പ്രത്യേകത.
Vaishak audible അല്ലേ?
There was technical problem for a short while. So ARDS, we are going to the definition. It's a clinical syndrome of severe dyspnea of rapid onset, and there is diffuse pulmonary infiltrates, which will lead on to respiratory failure and hypoxemia. So what do you mean by rapid onset? Some technical problem again.
Ma'am,
ഹലോ മാം, അൺമ്യൂട്ട് ചെയ്തിരിക്കുകയാണ്. മ്യൂട്ട് ചെയ്തിരിക്കുകയാണൊന്നും കേൾക്കുന്നില്ല.
ഇപ്പൊ കേൾക്കാവോ?
ഓക്കെ മാം.
ഇത് കുറച്ച് ടെക്നിക്കൽ പ്രോബ്ലംസ് ഉണ്ടെന്നാണ്. അപ്പൊ ആദ്യത്തെ സ്ലൈഡ് കണ്ടായിരുന്നല്ലോ അല്ലേ?
യെസ് മാം.
So I told you it's a rapid onset thing. So what is that acute onset? The duration is 1 week or less than 1 week. And bilateral opacities, I told you. So bilateral opacities will be there on chest imaging, but these images cannot be fully explained by cardiac failure or fluid overload. So what is the problem with differentiating between ARDS, cardiac failure? We will discuss it later. Okay. So can you hear it? Okay. Okay. So the pinning prasnam. Okay, so now we are going to the etiology. ARDS is caused by a diffuse lung injury from underlying medical and surgical diseases. And this lung injury may be due to a direct injury as in a toxic inhalation, or it may be indirect injury as in a sepsis. So ARDS is due to an underlying medical or surgical disease. So these are some of the etiologies associated with the ARDS. Some they are associated with the direct lung injury, some with indirect lung injury. But the pneumonia along with sepsis, pneumonia along with sepsis accounts for about 50% of the cases of ARDS. Okay, and other causes include aspiration of gastric contents, severe trauma, which include burns, then multiple transfusions, drug overdosage. And of these, the commonest is, the most common is pneumonia with sepsis. It accounts for about 50% of cases. Next, we will go to clinical codes and pathophysiology. Both will go hand in hand. So we are discussing it together. So this is the picture taken from Harrison. So on this half, there is normal alveolus, and this half, you need not bother now. We will explain later. So in the normal alveolus, this is the alveolar airspace, and this is an alveolar macrophage. Then this arrow shows the alveolar epithelial cells, and this is the type 1 pneumocytes, and this white line is the surfactant, and this blue line is the alveolar basement membrane. And this is type 2 pneumocyte, which secretes the surfactant. This is the fibroblast. Here, this is the interstitium, and this is the capillary and capillary endothelial cell. So you see the cells are tightly packed together. There is no gap between the alveolar epithelial cells or the capillary endothelial cells. So what happens in ARDS? The ARDS, the natural history is marked by 3 phases. One is the exudative phase, next comes proliferative phase, then the fibrotic phase. Each phase has a characteristic clinical and pathologic feature. We will come to each one. First is exudative phase. What happens in exudative phase? There is injury to alveolar epithelial cells, that is type 1 pneumocytes, not type 2, and the alveolar capillary endothelial cells. So I told you they are tightly packed, there is no gap between cells. But when there is injury, there is loss of this normal tight alveolar barrier to fluid and macromolecules. So fluid and macromolecules will enter into the alveolar airspace. You can see here that this tight junction is lost in the alveolar epithelium as well as in the capillary endothelium. So there is a gap formation. Okay. So what happens when these macromolecules enter into the alveolar space? There will be accumulation of protein-rich edema fluid in the interstitial and alveolar spaces. You see there is protein-rich edema fluid in the alveolar space as well as in the interstitium. There is interstitial edema. You see, the interstitium is widened with edema here. Okay. Then, due to the presence of these macromolecules, the pro-inflammatory cytokines, pro-inflammatory mediators are released, including interleukin-1, 8, 6, tumor necrosis factor, and so many things. So these are there, the interleukin-1, 6, 8, tumor necrosis factor, alpha, all these things are released. So in response to these pro-inflammatory mediators, leukocytes, especially neutrophils, will traffic into the interstitium and alveoli. You see, from the capillaries, these polymorphonuclear leukocytes traffic into the interstitium as well as into the alveoli. These are the migrating neutrophils. And I told you there is protein-rich edema fluid in the alveolus, and these proteins along with cellular debris and the dysfunctional surfactant. The surfactant is dysfunctional in ARDS. So all these things condense together to form a hyaline membrane. You see, there is edema, there is cellular debris, then dysfunctional surfactant, and fibrin. All these things together form a hyaline membrane. Okay, so that is this thing in exudative phase. Along with all these things, in the exudative phase, I told you there is endothelial injury. So pulmonary vascular injury is present in the early ARDS. So that will lead on to vascular obliteration by microthrombi. So that will also occur. There is vascular occlusion due to microthrombi is also there in ARDS. So this is what we have explained till now. The gap due to the gap formation, all these things happened in the exudative phase. Okay. So this is the picture in Harrison's textbook. So I tried to make it simple. So in exudative phase, there is formation of alveolar edema and microvascular occlusion. So due to alveolar edema, this alveolar edema predominantly involves the dependent portions of the lung. That is very important in ARDS pathophysiology. So this areas there is diminished aeration and atelectasis. This will markedly reduce the lung compliance and which will lead on to hypoxemia. Okay. So microvascular occlusion, I told you there will be presence of decreased pulmonary arterial blood flow due to this microvascular occlusion, and that will lead on to pulmonary arterial hypertension. So due to hypoxemia, there is increased work of breathing and patient will, the symptom of dyspnea will manifest. So one more thing that you have to remember is in early ARDS, in addition to severe hypoxemia, hypercapnia will also be there due to increase in pulmonary dead space. So both hypoxemia and hypercapnia are present in early ARDS. Then what is the time course for development and resolution of ARDS? I told you the pathophysiology and clinical symptoms go hand in hand. So in the exudative phase, this exudative phase encompasses the first 7 days of illness after exposure to the factor, that is pneumonia or sepsis. Okay, so this encompasses the first 7 days, and there will be respiratory symptoms. And patient presents with 12 within. Usually patient presents within 12 to 36 hours after the initial insult, and it can be delayed up to 5 to 7 days also. Okay, and dyspnea will develop with a sensation of rapid shallow breathing. It will be maybe acidotic, and ultimately it will lead on to respiratory failure. Okay, so first 7 days is exudative phase. So we discussed about exudative phase. Now we are going to the proliferative phase. So this proliferative phase usually lasts from day 7 to day 21. Usually, most patients recover rapidly and are liberated from the mechanical ventilation during this phase. But many still experience tachypnea and hypoxemia. Some will develop progressive lung injury and early changes of pulmonary fibrosis, and they will go into the fibrotic phase. So proliferative phase, mostly a patient will recover. Histologically, the proliferative phase shows the first signs of resolution. What proliferates in the proliferative phase? Something should proliferate, no? So type 2 pneumocytes will proliferate along the alveolar basement membrane. And this is the type 2 pneumocytes I told you. And these type 2 pneumocytes will synthesize new pulmonary surfactant. So in ARDS exudative phase, the surfactant was dysfunctional. So this in proliferative phase, the type 2 pneumocytes will synthesize new pulmonary surfactant, and they will also differentiate into type 1 pneumocytes also. And the exudate will change from a neutrophil predominant one to a lymphocyte predominant one. So exudative phase, proliferative phase, now we are going to the fibrotic phase. So I told you many will recover within 3 to 4 weeks, but some enter into the fibrotic phase, and they may require long-term ventilatory support or supplemental oxygen. In the fibrotic phase, there is fibrosis. So there is exudates and alveolar edema will be converted into fibrosis. Though that fibrosis will be there in the alveolar duct as well as in the interstitium. And this fibrosis will disrupt the acinar architecture. So what will happen? There will be emphysema-like changes, and due to this emphysema-like changes, there will be large bullae formation in the lungs. And when there is large bullae, what is the complication? There is pneumothorax. So emphysema-like changes, large bullae formation, and increased risk of pneumothorax, all these things are complications of fibrotic phase. There is intimal fibroproliferation, the microcirculation. So there will be vascular occlusion, as I told you earlier. There will be microvascular occlusion, and that will lead on to development of pulmonary arterial hypertension also. So in a summary, I told you in the exudative phase, there is early alveolar edema and hyaline membrane formation. In the that is 7 days, edema and hyaline membrane formation in the exudative phase, first 7 days. Then proliferative phase ensues within 7 days, and there is type 2 pneumocytes proliferation, interstitial inflammation, and early fibrotic changes will occur. So that is up to 21 days. Then there is, and about 3 weeks after the initial pulmonary injury, most patients will recover, but some enter into a fibrotic phase with substantial fibrosis and bullae formation. So exudative phase, proliferative phase, fibrotic phase. Exudative phase, edema and hyaline membrane. Then proliferative phase, type 2 pneumocytes proliferate. There is interstitial inflammation, and many showed signs of recovery. Some will progress to fibrotic phase, and the complications of emphysema-like changes, bullae formation, development of pneumothorax can occur, and pulmonary arterial hypertension. So now we are going to the investigations. Investigations, the laboratory investigations are generally non-specific and which will indicate only the underlying clinical disorder which caused the ARDS. Okay. So the chest X-ray is one of the common investigations, and you can see that this chest X-ray is showing diffuse interstitial and alveolar infiltrates, but it is difficult to distinguish from left heart failure. Okay. So the points to differentiate a left heart failure from ARDS in the chest X-ray is there will not be any cardiomegaly, there will not be any pleural effusion or pulmonary vascular redistribution. I will come to it later. In the X-ray also you can see that the dependent portions are more affected than the non-dependent areas. So how will you differentiate? This is a normal X-ray. You can see this is a normal X-ray. You can see that the vascular markings are more towards the lower areas and it is less towards the upper zone. So in ARDS, you can see that there is bilateral diffuse infiltrates. But in cardiac failure, you can see that the vascular markings are more towards the upper zone. So this is known as redistribution of vascular markings, and it is called as cephalization. So this will be present in left heart failure, not in pulmonary, in ARDS. But in cardiac failure, there will be a cardiomegaly, increased cardiothoracic ratio. So there is cardiomegaly. You can see small horizontal lines here. They are curly B lines. Those will be present in left heart failure, not in ARDS. And you can see pleural effusion in heart failure. That this is horizontal fissure, and fluid is entering into the horizontal fissure. That is why we are seeing it like this. So all these things, pleural effusion, cephalization, cardiomegaly, curly B lines, all will point towards a heart failure. Okay. Then CT. Just CT in the exudative phase will show alveolar edema. Here also you can see that it is the dependent areas that are affected. So dependent alveolar edema and atelectasis will predominate in the CT. And early features of ARDS are non-specific. So you have to think of alternative diagnosis also. So you have to think of the differential diagnosis. So what are they? So now we are going to the differential diagnosis. So I told you cardiogenic pulmonary edema. So cardiogenic pulmonary edema, neurogenic pulmonary edema, then diffuse pneumonias, alveolar hemorrhage, all these things are common differential diagnosis. Then less common, acute interstitial lung disease like an interstitial pneumonitis, acute immunologic injury like hypersensitivity pneumonitis, toxin injuries, neurogenic pulmonary edema, all these things are uncommon causes. But we should also keep in mind that these conditions may also give a similar picture in the X-rays. So cardiogenic pulmonary edema is the commonest differential diagnosis that you should consider. So these are the diagnostic criteria for ARDS. Here this is severity according to the oxygenation. Then next is onset. Onset, I told you it should be acute, that is 1 week or less. Then chest X-ray, I showed the bilateral alveolar or interstitial infiltrates, bilateral infiltrates. And the next thing that you should have in the diagnostic criteria is absence of left atrial hypertension. That means if you can measure the pulmonary capillary wedge pressure, it's okay. Then it should be 18 millimeters of mercury or less. Or you can take it clinically also, or there is no clinical evidence of increased left atrial pressure as evidenced by left atrium. So is there any S3, LV, S3 like that. So you can see if you have to rule out the clinical evidence of increased left atrial pressure. You can do an echo and see also. So this is severity. This is according to oxygenation. It is by PaO2 by FiO2. FiO2, I will come to it later, but FiO2 is the fraction of inspired oxygen in the air. That is, when we are inhaling the atmospheric air, the percentage of oxygen, fraction of oxygen is 21%. So that is the fraction of inspired oxygen is FiO2. So that we will get in the when we are connecting the patient to the ventilator, I will describe it, all these things. So PaO2 by FiO2 should be less than 300 but up to 200. Okay, and then it is mild. If PaO2 by FiO2 is 200 to 100, 100 to 200, okay, then it is moderate. Then severe, if the PaO2 by FiO2 is 100 or less, it is severe. So this is how you assess the severity. And the onset should be acute. Chest X-ray should show the bilateral alveolar or interstitial infiltrates, and you should rule out a left atrial hypertension also. So now we are going to the management. So in the management, as in any other case, there will be some general principles. Okay, general measures will be there. So you have to treat the underlying disorder, whether it is a sepsis, whether it is aspiration, trauma. So you have to treat the underlying cause. Okay, that's very evident. Then you have to minimize the procedures, avoid unnecessary procedures and their complications. Okay, then you have to give prophylaxis. The patient will be ventilated, so I mean there is chance for DVT, thromboembolism, everything is there. So venous thromboembolism, the DVT. So you have to give prophylaxis. You have to give low molecular weight heparin or unfractionated heparin. So you have to give prophylaxis against venous thromboembolism. Patient can develop gastrointestinal bleeding, aspiration. So patient is in sedation, no? So aspiration can occur. You have to prevent that. Excessive sedation should not happen. You have to put a central venous catheter in ventilated patients. So you have to avoid central venous catheter infections. So prophylaxis against all these things is very, very, very important. Okay. And you have to promptly recognize the nosocomial infections, and you should not forget about provision of adequate nutrition. Okay, so these are the general principles. And treat the underlying disorders, prophylaxis against thromboembolism and all these things, then provision of adequate nutrition. All these things should also be given attention. So coming to mechanical ventilation, I know none of you are familiar with mechanical ventilation, but you should know something about the mechanical ventilation. Otherwise, the management of ARDS will not be complete. So I told you there is increased work of breathing and progressive hypoxemia. So the patient will become fatigued and patient requires mechanical ventilation. So with mechanical ventilation, we are trying to correct the hypoxemia. So not the underlying condition. So you have to treat the underlying pneumonia and sepsis separately. Okay. So this is a pictorial presentation of a ventilator. So you see, this is this mechanical ventilator blows air or air mixed with increased oxygen. We want to correct hypoxemia. So air mixed with increased oxygen through tubes into patient's airways. These are the tubes, and through these tubes, the air will go to the patient. And the endotracheal tube goes through the patient's mouth into the trachea. Then, so this is how we are delivering oxygen to the patient's lung. Then exhaled air flowing away from the patient is going through this tubing to the ventilator. Okay. So this is the, inflow of air and the outflow of air. Then there will be a monitor, and this monitor will show the so many findings. So in the monitor, there will be so many things, but you should know some of the monitoring points that we should know in uh, uh, this mechanical ventilation in ARDS. So one is FiO2. This terminology I will explain. FiO2, what is PEEP or positive end expiratory pressure? So there was a problem with the power supply. So I told you, you should know about FiO2, PEEP, that is positive end expiratory pressure, respiratory rate, everybody knows. Then tidal volume and inspiratory expiratory ratio. So I will explain it each one. So I told you from the ventilator, air or air mixed with oxygen is given to the patient through the endotracheal tube. So FiO2 is the fraction of inspired oxygen. That is, oxygen is added to the air that is used to provide mechanical ventilation, and the concentration of oxygen in the air that we breathe or the patient breathe is called the FiO2, that is fraction of inspired oxygen. In the atmospheric air, it is 21%. And when we are putting the patient on ventilator, initially we will give 100% oxygen. So FiO2 is 100%. But oxygen itself, 100% oxygen itself is toxic to the tissues if you give for a long time. So we have to reduce the FiO2 as the time progresses. Okay, so that is the fraction of inspired oxygen that we can adjust in the ventilator. So you should know what is FiO2. Then what is post end expiratory pressure or PEEP? So in this picture, you can see that this is an alveolus, and during inspiration, it will distend. It will distend, and during expiration, that distension will go, but due to the presence of normal surfactant, it will not, the alveolus will not completely collapse. It will be slightly distended. But in ARDS, I told you, in the ARDS, in the exudative phase itself, the surfactant is dysfunctional. So without surfactant, this alveolus will collapse and that will become sticky. So this should not happen. You should give a pressure at the end of expiration. You have to keep a pressure so that the alveolus is slightly distended. It should not go into a complete, sticking, sticking procedure. So that pressure, the pressure in the lungs above the atmospheric pressure that exists at the end of expiration, that to prevent the collapse of the alveolus. That pressure that we give in ARDS is the PEEP. Not in ARDS, in all ventilatory settings. It is PEEP, positive end expiratory pressure, that will prevent the alveolus from collapsing. Then what is tidal volume in a mechanical ventilator, not in the normal situation? I told you the ventilator will give volume of air with each breath. If you are setting the respirator rate as 15, then the ventilator will give 15 breaths in 1 minute. If you are setting the respirator rate as 35, then ventilator will give 35 volumes of air into the patient's lung. So the volume of air delivered to the lung with each breath by the mechanical ventilator. With each breath, what is the volume of air given to the lung? That is called as tidal volume, or PT. It is not TV, it is VT in a ventilator. So the next terminology is IE ratio, or inspiratory expiratory ratio. In a normal setting in the ventilator, we will set, that is the time, that is inspiratory expiratory ratio refers to the ratio of inspiratory time to expiratory time. So in ventilatory setting, usually we give more time for expiration. So it is not 1:1, it is 1:2. But in ARDS, we have to give more time for inspiration, so that we are inversing the ratio of IE ratio. So it is called as inverse ratio ventilation. That is, we will set the IE ratio as 2:1. We are giving more time for inspiration. It is called inverse ratio. So that is the setting in ARDS. So that is inspiratory expiratory ratio is the ratio of inspiratory time to expiratory time. So this is the example of a monitor. This is not for ARDS. This is a monitor setting. There are different modes of ventilation: volume control, volume assist control, pressure support, SIMV, so many modes. But here we are taking volume control. Then these are the things I described now. That is, this is FiO2. So here it is FiO2 is 100%, and this is P, positive end expiratory pressure. So that is set as 5. We can arbitrarily set it. Then this is the respiratory rate setting. We can set the respiratory rate. Here it is set as 15. It is not for ARDS. Then this is the tidal volume. That is the volume of air given to the patient with each breath. That is tidal volume. Here it is set as 500. This is not for ARDS. Then here you can see the inspiratory expiratory ratio, IE ratio. That is the ratio of inspiratory time with expiratory time. Here it is 1:3, something like. So this is not for ARDS. Okay. Just get familiar with, there are so many other things you need not know, but this much you should know. What is it? What is tidal volume? What is PEEP? You should understand. Why? Because ventilator can induce lung injury. Ventilator is not 100% safe unless you use it in the correct way. So despite its life-saving potential, mechanical ventilation can aggravate the lung injury. So the ventilator-induced lung injury require two processes. One is repeated alveolar over distension so that it will rupture, or recurrent alveolar collapse. So this over distension and collapse should not occur when you are using a ventilator. So ventilator-induced lung injury. In ARDS, you see, I told you, ARDS principally involves the dependent portions of the lung with relative sparing of the other regions. So this region can take part in oxygenation in almost in a normal way. So we have to protect this normal area. So in the CT also, you can see the dependent areas are more affected, and this area is almost spared. And this area, we will call it as a baby lung, because only this much area of this lung is normally functioning. So we have to protect this baby lung. You see in this picture, you can see that in the dependent portion, it is almost consolidated. In the intermediate portion, it is consolidating. And in this is the spared area. So we have to spare this, we have to protect this baby lung area. So compliance differs in affected than normal areas of the lung. The attempts to fully inflate the consolidated lung may lead to damage to the normal lung. It will lead on to the over distension or an injury to the more normal areas. So when we are giving more volume with each breath, that is high tidal volume or a usual tidal volume, this area we can distend, but this area will rupture. So that should not happen. So we should give a low tidal volume ventilation, that we have to give less volume of air with each breath. Okay, is it clear to you? Yeah. So I told you the tidal volume is the volume of air delivered to the lung with each breath by the mechanical ventilator. So you have to give a low tidal volume ventilation to protect the normal areas of the lung. Usually in the conventional ventilatory method, we will give a tidal volume of 12 ml per kilogram of predicted body weight. But in ARDS, you have to give a low tidal volume, that is 6 ml per kilogram of predicted body weight. This is the most substantial ARDS mortality benefit shown from any of the studies conducted so far. So this is very, very important, low tidal volume ventilation. You must keep this word in mind. Then I told you what is PEEP, that is positive end expiratory pressure, that the pressure in the lungs above the atmospheric pressure that exists at the end of expiration. So due to absence of surfactant, the alveolus will collapse. So you should prevent this collapse by giving a PEEP. So in ARDS, presence of alveolar and interstitial fluid and loss of surfactant will lead on to markedly decreased lung compliance. So you have to give a PEEP, and that we will arbitrarily set the PEEP. Okay, you need not know all these things. So the thing that you have to remember is it is advisable to set the PEEP. We are setting the PEEP to minimize the FiO2. I told you high oxygen concentration is toxic to the tissues on long-term use. So we have to minimize the FiO2 and we have to optimize the PaO2. So this is a ARDS net protocol. We can set the FiO2 and PEEP, so that we can minimize the FiO2 and we can optimize the PaO2. So coming to the IE ratio, I told you, normally we will keep it as 1:2. We will give more time for expiration. But in ARDS, an inverse ratio ventilation, that is, we have to give more time for inspiration. So it is 2:1 or higher. That is typically used to ventilate non-compliant lungs like ARDS. Then you should know the recruitment maneuvers. The recruitment maneuvers will recruit the atelectatic lung, and there are some recruitment maneuvers, and these will recruit the atelectatic lung, and you can increase the oxygenation. So one thing is prone ventilation. It is very much discussed nowadays in ARDS, that is prone ventilation. Patient is kept in the prone position, but this will increase the arterial oxygenation, but it can be hazardous also, because it can lead on to the accidental endotracheal extubation. Patient is in the prone position, loss of central venous catheters, then orthopedic injury. So it can be hazardous also, but it will definitely improve the arterial oxygenation. But you must remember that this is not the primary method of ventilation. This is an alternative method of ventilation. So there are other strategies for mechanical ventilation ARDS, but no survival benefit has been shown in various studies. So but you should know about ECMO also, extracorporeal membrane oxygenation, ECMO. So this provides a clear survival benefit in neonatal RDS, but it may also have some utility in selected adult patients with ARDS, but we are not using ECMO now. So I told you there are adjunctive ventilator therapies like high PEEP, inverse ratio ventilation, recruitment maneuvers like prone positioning, ECMO, PLV. All these are reserved for use as rescue rather than primary therapies. So mechanical in the management, there were some general principles, then mechanical ventilation, and third is fluid management. So fluid management, we are discussing about lungs, but we should also, think of the heart. So in ARDS, there is increased pulmonary vascular permeability, which will lead on to interstitial edema as well as alveolar edema. So there is pulmonary edema. So you have to decrease this pulmonary edema so that you can decrease the duration of mechanical ventilation. So decrease the left atrial filling pressure with fluid restriction and diuretics. So fluid management is also a very important part in the management of ARDS. Okay, so fluid restriction and diuretics, but you should avoid a hypotension, and you should keep in mind that hypoperfusion to critical organs like kidneys can occur. So you have to monitor that also. So you have to think about heart along with lungs. Then the next treatment modality, one point is neuromuscular blockade. The patient will be restless. So you have to, sometimes you have to give a neuromuscular blockade, not always. Early administration of neuromuscular blockade, if needed, to facilitate the mechanical ventilation in severe ARDS, if needed, not always. Then previously, we used to give glucocorticosteroids, but now glucocorticoids are not used in ARDS. There is no evidence to support high dose glucocorticoids in ARDS now. So what are the evidence-based recommendations in ARDS? These are there. So evidence-based means A means level, A means there is a strong clinical evidence, B means supportive. But so in all these treatment modalities, level A recommendation is only for low tidal volume ventilation and early neuromuscular blockade. Even the fluid therapy, minimized left atrial filling pressure. So fluid therapy itself has only a B level recommendation. So A level recommendation is for low tidal volume. So that must be kept in mind. Prone position, recruitment maneuvers all have C level ventilation, level evidence. That means recommended only as an alternative therapy. Okay. So A level is low tidal volume ventilation. Results of large clinical trials must be judiciously applied to individual patients. Okay. So this is the management of ARDS in the initial setting. First, initiate volume ventilation, volume control ventilation. That is, I told you different modes are there. So start with volume or pressure limited ventilation. The goal is tidal volume. I told you low tidal volume, 6 ml per kilogram of predicted body weight or less. Then you need not go for these two. Then the respiratory rate should be 35 or less than 35. Then you give oxygen, oxygenate, so as to keep the FiO2 0.6 or less. That is high, it will be toxic to the tissues. Then PEEP, we will arbitrarily keep it, and it should be less than 10. SpO2, usually we will in all other settings we will see that the SpO2 is above 95%, but in ARDS you can keep the SpO2 between 88 to 95%. That is sufficient. So oxygenate, Then minimize acidosis. During mechanical ventilation, we will frequently check the ABG, arterial blood gas. So you should minimize the acidosis. The pH should be 7.3 or more, and respiratory rate less than 35. Then keep the fluid management. You can give diuresis, avoid hypoperfusion. So oxygenation, minimize acidosis, and diuresis. So what is the prognosis? Mortality range from 26% to 44%. So high mortality. Mortality in ARDS is largely attributable to non-pulmonary causes like sepsis and non-pulmonary organ failure. So more than 80% of the mortality is due to non-pulmonary causes. The poor prognostic indicators are above 75 years of age, pre-existing organ dysfunction like chronic liver disease, cirrhosis, chronic alcohol abuse, immunosuppression, sepsis, CKD. All these things are poor prognostic indicators, and ARDS arising from direct lung injury. So we have discussed about the definition, etiology, clinical course and pathophysiology, investigations, differential diagnosis, management. In the management, we discussed about the general principles, mechanical ventilation, fluid management, evidence-based recommendations. So this was the definition I told you. Then I told you the etiology, pneumonia, and sepsis account for more than about 50% of the causes. This was the pathophysiology, exudative phase, proliferative phase, and fibrotic phase. Exudative phase, alveolar edema, hyaline membrane formation. Proliferative phase, type 2 pneumocytes. Then fibrotic phase, fibrosis, bullae formation. Then how to differentiate between, you have to differentiate from left heart failure. How to differentiate, I told you. Then it was the CT, dependent alveolar edema, and atelectasis predominate in this. And what is the diagnostic criteria for ARDS? How will you classify the severity? Then a word about mechanical ventilation. This was what is FiO2, PEEP, respiratory rate, and tidal volume. Recruitment maneuvers like prone position. Then importance of fluid management and algorithm for management. What are the poor prognostic indicators? So I hope you could understand this class. So you're all staying in your home. So please stay safe. Okay, thank you. Any doubts? Okay. So if there are no doubts, okay, we can write the class.
Thank you, ma'am.
വന്നിട്ടില്ലേ?
വീഡിയോസ് മ്യൂട്ട് ചെയ്തിരിക്കും.
മൈക്ക് കേട്ട് പറഞ്ഞാൽ മതി. എത്ര പേരുണ്ട് ലൈവ് കാണാൻ പറ്റുമോ? ഓക്കെ, എല്ലാരും മ്യൂട്ട് ചെയ്തിരിക്കുകയാണല്ലോ. Okay. Hello students, I'm Dr. Anish from Department of Surgery. Can all of you are muted the mic? Can you unmute for a second? Okay. Yes. Hello, everyone. How everything is going on? Hello, Lavanya. How are you spending the time? Anyone from S1 unit? Yes. Can you see? അഞ്ചാറ് വരെ ഉള്ളല്ലോ അല്ലേ? വരില്ല ഓർഡറിലല്ല. കുറച്ചുപേരുണ്ട്. അനീറ്റ, can you hear? Anita, can you hear?
Yes, sir.
Yes. Okay. Today our topic is parotid tumor. Last Monday we could not conduct the class. We had a Zoom meeting with HODs. So we will take parotid tumor today. The DVT will be on next Wednesday or Monday. Okay, Anita. Then now you can unmute. You can mute because there is a lot of background noise are coming. Okay. Then please look in the slides. Today our topic is parotid tumor. It is the largest parotid gland. It's the largest parotid gland. Everybody knows. Simple question. Largest salivary gland is parotid gland. Okay. Then today we are discussing about tumors from parotid gland. Next. Okay. First, briefly about salivary glands. Salivary gland all are exocrine glands. There are main three salivary glands: parotid, submandibular, and sublingual. All of three of them are paired salivary glands. Numerous minor salivary glands are there. Yes. The parotid is purely a serous gland. Other sublingual is a mucous gland. Other submandibular is mixed gland. These are the major paired glands are parotid, submandibular, and sublingual. Other are sublabial, buccal, palatal, palatoglossal, minor salivary glands. We all studied that the parotid fascia is developed by investing layer of deep cervical fascia. But there is a newer concept is that like the platysma muscle, parotid fascia is formed by the fascio-aponeurotic layer of the face. That is SMAS, superficial musculo-aponeurotic system of the face. That is the anterior layer. Otherwise, superficial layer. The posterior layer is deep cervical fascia. So there is a new idea about the capsule of parotid. Most of the books described as splitting of deep cervical fascia. Now you can see a detailed view of parotid gland. It's the parotid gland. You can see the duct. The main thing we should see is that this is a digastric muscle. Can you see this? Digastric. Carved around the hyoid bone. There is a pulley. This anterior belly, this posterior belly. It's very important. Can you see this vessel? It's artery. That is the branches of external carotid artery. You have to study the branches of external carotid artery. It's a superficial temporal artery. There are some other arteries inside the parotid gland. Can you say what are the other glands, other vessels inside the parotid gland? It is maxillary artery, transverse facial artery, and postauricular artery. Okay. Then you can see other glands. Submandibular gland and mylohyoid divides it into deeper part and superficial part. It's the mylohyoid muscles. Then sublingual gland. Sternocleidomastoid. Okay. So you can have this PPT. You can see this. You can save this picture. It is a very informative picture. Then next is a symbol diagram for parotid duct. Parotid duct anteriorly through the masseter, piercing the vaccinator and opens the against the second molar. Okay. Do you know what is ossia parotidis? What is ossia parotidis? Yeah. You can find out ossia parotidis. How this name parotid came? Behind the otis, para otis. That is parotid. Okay. And now you can see the parotid duct entering inside the second molar tooth. Okay. So another view of parotid gland, cross-sectional view. Yeah. Can you see this foramen? Stylomastoid foramen, styloid process. These are very important landmark. We can discuss later in slides about the landmarks of facial nerve. There we can use all this. This is styloid process. Okay. So branches of facial nerve. Can you see? Facial nerve gives branches to at the origin. Facial nerve gives branches to the posterior belly of digastric postauricular. Then it divides into 5 branches. Okay. Then these branches, you should study these branches because the evaluation of facial nerve palsy based on these branches. Okay. Now you can see a anatomical description of facial nerve, exit of facial nerve from stylomastoid foramen. Can you this? It is coming out through this stylomastoid foramen. This is the mastoid process. This is a styloid process. Stylomastoid foramen. It's a tympanic cavity, tympanic ring. It's a tympanomastoid suture. The other suture means the line joining the bone, like the frontal suture, occipital suture. Is a tympanomastoid suture. Nothing else. Can you see? This is a tympano, just behind. The mainly we use the this landmark is the styloid process. We can when you become house surgeons, you can see the surgery, superficial parodectomy. We can locate this styloid process and palpate the styloid process and isolate the area of probable facial nerve exit. It's very difficult while during surgery. On this diagram, it is very simple. Just behind the styloid process. So these are the landmarks. It's a cartilaginous pointer. Okay, this is another picture. Supposed to be left digastric, styloid. Okay, facial nerve exit. Then the innervation of parotid gland. Parotid gland has sensory, sympathetic, and parasympathetic innervations. The sensory is by auriculotemporal nerve and great auricular nerve. Parasympathetic from inferior salivatory nucleus, then glossopharyngeal nerve, then tympanic branch of lesser petrosal nerve, optic ganglion via auriculotemporal nerve. The parasympathetic supply, you have to write it down and keep a note. You have to write down make a note on facial nerve. Otherwise, you will forget. Parasympathetic supplies usually we forget. Inferior salivatory nucleus, then ninth cranial nerve, then lesser petrosal nerve, then optic ganglion through the auriculotemporal nerve. Sympathetic supplies from superior cervical plexus, nothing difficult. Okay, you can see the facial nerve. So, superior salivary nucleus, motor nucleus of the facial nerve, then the motor part and the nervous intermediate joints outside the bones. Then through the internal auditory meatus, there is a genu. This is geniculate ganglion. Here it gives two branches: greater petrosal nerve, lesser petrosal nerve. Okay. This is the genu branches. Then after this genu, it will give a nerve to stapedius. Because when we study about the facial nerve palsy, Bell's palsy, facial nerve palsy, or sometimes following trauma, facial nerve palsy can occur. So hyperacusis develops because the nervous to stapedius is not working, not relaxing. Then through the coda tympanic nerve, facial nerve supplies anterior two-third of tongue, taste fibers of anterior two-third of tongue through lingual nerve. Then other two salivary glands. As you shown earlier, there is a branches to digastric, stylohead, and postauricular branch, and other 5 major branches of facial nerve. Usually, the facial nerve is injured at the site of exit, stylomastoid. So these 5 branches usually affected: temporal, zygomatic, buccal, marginal, mandibular, and cervical. Okay, this is a parasympathetic. I have already told you that is a inferior salivatory nucleus. You can see this green line. This is a cranial nerve, glossopharyngeal nerve, through the tympanic plexus, then lesser petrosal nerve. It's a trigeminal. Mandibular branch of trigeminal gives auricular temporal nerve. Ophthalmic, maxillary, mandibular. This is the auricular temporal. Through this auricular temporal nerve, it supplies the, can you see this green line? Inferior salivatory nucleus, ninth nerve, tympanic plexus, optic ganglion, auricular temporal nerve. Okay, this is about the supply, parasympathetic supply. Then we can have some other pathologies, parotid swelling. like can cause in silolithiasis, infections, tumor, and systemic diseases. Okay, we here discuss more about tumors. So we can go to risk factors of parotid tumor. Okay, these are the risk factors. You can see infective pathologies. Then it's the Epstein-Barr virus. Then post-radiation, post-atomic bomb explosion survivors, workers in rubber manufacturing, plumbing industry, nickel compounds, and smoking. These are the risk factors. These are some of the MCQs usually asked in exams, like NEET exams. What are the most common gland to affect tumor? That is parotid. Majority of the salivary gland tumors are benign parotid tumors. 80% of the affect superficial lobe, 80% of pleomorphic adenomas. So usually don't ask about these questions in theory exam. It is only in MCQ exams like NEET. The 50% tumors in submandibular gland, the 90% of the minor salivary gland. Can you see it is a bigger gland, the most of the tumors are benign. Coming to the minor salivary gland, the most of the tumors are malignant. Okay. Some of the peculiar features of the parotid tumors. It's a slow-growing tumor over there, probably a pleomorphic adenoma. Old age man with a history of smoking, bilateral tumor, Warthin's tumor. Actually, painful parotid tumor is adenoid cystic carcinoma. Maybe sometimes this pleomorphic adenoma can rapidly enlarge, can cause facial palsy, numbness in the ear, difficulty in opening. What do you mean by difficulty in opening of mouth? It is affecting the TM joint and the masseter muscle. Tumor is infiltrating to the muscle or joint. Okay, there may be neck nodes. Superficial upper cervical nodes are the drainage area for parotid glands. Okay, then benign is over. The most malignant tumor is mucoepidermoid carcinoma. Okay, because this most commonly in parotid, submandibular most commonly is adenoid cystic. These are all MCQs you can remember while writing NEET exam. Most common in childhood is mucoepidermoid carcinoma. Painful is more in adenoid cystic carcinoma. Usually, squamous cell carcinoma is associated with skin ulceration. Then, investigation for parotid tumor. Okay, ultrasound. It's the first line investigation. You can see about the effectiveness. Can differentiate solid cystic nodes. Can also take guided FNACs. X-ray, you can see stones. Okay. And xylography. Other is neck, CT neck. When there is a malignancy with infiltration to bone, muscle, and deep lobe involvement, we need CT neck. Okay. MRI we usually use in. We have initially done a parotid surgery. After 10 years, patient complains with salivary parotid swelling. We can assess local spread more effectively. Okay. It's for silolithiasis. Okay. The FNAC we use Millen system of reporting salivary glands. Here in reporting you can see MSRSGC1, that is non-diagnostic, does not yield any parotid tissue. Maybe blood only. You may have seen some parotid, some FNAC reports like blood only. That's non-diagnostic. ROM means risk of malignancy. It is 25%. We have to repeat the biopsy. Type 2 is non-neoplastic. It's very important. Newer guideline for FNAC is this Milan criteria. Type 2 is non-neoplastic. 10% risk of malignancy. AUs, ATP of undetermined significance. That is 20% chance. And then type 4 is neoplasm. Benign, type 4A, malignant. The neoplasm of uncertain malignant potential is 4B. It has got 35% chance of malignancy. Then we are type 5, suspicious of malignancy. Type 6, malignancy. Okay. First 3 are mainly benign, 4 up to 4A. Last 3, then there is neoplasm, malignancy, suspicious of malignancy, and malignant. Tissue diagnosis, we usually use FNAC. Why don't we do open biopsy or true cut biopsy? Because tumor may seed to the skin, can cause parotid fistula, facial injury, hemorrhage. Then we can do core biopsy. We strongly suspect there is a chance of lymphoma. So we can do a guided core biopsy. Okay. Otherwise, we can do ulcerated lesions. We can cut a margin of the ulcer. Anyway, the lesion is open. And like in parotid fistula, there is a openings there. So we can, at that cases we can do an open biopsy. Why there is a submandibular gland is more prone to silolithias. These are the two causes. Anti-gravity is going upwards, so anti-gravity flow. There is a long duct, okay, more mucous secretions. These are the causes. This is silolithiasis usually a spasmodic pain usually following just before food intake. When the salivary secretions develop, there will be a block and there will be a spasmodic pain. Okay, X-ray will show. We already see stones. You can remove by extraglandular transoral silolithotomy or lithotripsy or silodidectomy. Chronic cases, we can do submandibular silodidectomy. These are the tumors in salivary gland. Okay. Do you know about the course of parotid duct? Already told earlier. Yes, you all are muted. Sorry. The parotid duct, you can have a short note about parotid duct also. It's around 5 centimeter long. Opposite to the upper second, opens opposite the upper second molar tooth. Okay. Then okay. These are the WHO classification of parotid tumor. This is a short note. We can have a note for, about the tumors of parotid. These are benign tumors: pleomorphic adenoma, Warthin's tumor, monomorphic adenoma like oncocytoma, basic cell adenoma, canalicular adenoma, then myoepithelioma, cystadenoma, and papilloma. Other malignant are mucoepidoral carcinoma, adenocystic carcinoma, acinic cell carcinoma, rarely squamous cell carcinoma, adenosquamous carcinoma, carcinoma in pleomorphic adenoma, and adenocarcinoma. Lymphoepithelioma, we describe it as Eskimoma. It is highly prevalent in Eskimo population and this Chinese population. Okay. These are the malignant tumors. acidic cell tumor and mucoepidermoid. Mucoepidermoid tumor has three types: low, intermediate, and high. The low and intermediate tumors and acidic tumor including low-grade malignant tumors. High-grade tumors are high-grade mucoepidermal carcinoma, adenoid cystic carcinoma, carcinoma in previous pleomorphic adenoma, adenocarcinoma, squamous cell carcinoma, and lymphoepithelium. Okay. Sir, some point relating to the pleomorphic. As the name says, it's a pleomorphic. There are multiple type of cells: epithelial cell, myoepithelial cells, cartilaginous cells. They usually have a pseudo capsule around the tumor, and there is pseudopodia. Pseudopodia means the tumor extends to the anterior face, like a pseudopodia. Or long-standing, it can develop carcinoma ex pleomorphic adenoma, usually present as a painless, long-standing swelling, smooth swelling in front of the parotid. Warthin women, I already told you about old age male smokers. Bilateral is usually associated with TB, with the double layer epithelium with the papillary projection and lymphoid storm. It's also low-growth tumor. Other malignant tumors, major malignant tumors are you can have mucoepidermoid tumor. Okay, point you have to notice usually there is a cortical bone erosion and lymph node metastasis. Okay, when come to adenoid cystic carcinoma, there is a perineural invasion. So if there is a nerve infiltration during the surgery, sometimes we may need to do frozen section of the nerve and see the nerve is free of tumor. It is more in adenoid cystic carcinoma. Can track through the nerve. Okay, and is associated with the hematogenous branch. So TNM staging, the nodal staging is as like any other neck nodes. The TNM staging is very simple, based on 2 cm, less than 2 cm T1, 2 to 4 cm T2, more than 4 cm or extra parenchymal extension is 4 cm. Then T4 is tumor invading the skin, mandible, or external auditory meatus or facial. That is, we can remove. T4 is these are removable tumors. Then come to T4B, tumor is invading skull base, pterygoid plates, and carotid sheaths. Okay, the nodal stage, N1 is less than 3 cm, N2 A, B, C. That is single ipsilateral is 3 to 6 centimeters. All are less than 6 cm. That is more than 6 cm become N3. Okay, N2A is 3 to 6 centimeter ipsilateral. N2B is multiple ipsilateral, but all less than 6 centimeter. Okay. N2C is bilateral, not all less than 6 centimeter. Okay. N3 is more than 6 centimeter. So treatment. Okay. If it is a benign tumor, we can do superficial parodactomy. Do you know the facialness plane of Patty? Through this plane, we open the anterior fascia. You have to remember that name, facial-venous plane of Patty. Okay. If it is involved deep lobe, total conservative means we have to preserve the facial nerve. If it is a recurrent pleomorphic adenoma, or we need to give post-op radiation. Sometimes like a small Warthin's tumor, or some people do this just removal of the tumor with a rim of parotid gland. Nowadays it is not done. We usually do superficial parodactomy. For malignant tumor T1 and T3 up to T3 lesions, we can do conservative. We can preserve the nerve. On T4 lesions, the facial nerve is when the tumor is through the facial nerve or infiltration of facial nerve, we may need to remove the facial nerve. We can repair with sural nerve graft. Okay. If there is a knots, according to the site, you can do ipsilateral or bilateral MRNA. Okay. For all high-grade tumors and positive margins, we need to give radiation. This is it's about superficial pyroidectomy. It's a modified Blair or Lacey's incision. The mass flap is raised, then the sternocleidomastoid is dissected off the, and then you can see remember that first diagram. Sternocleidomastoid in the posteriorly sternocleidomastoid, you can remove the detach the sternocleidomastoid. Facial nerve is identified. Dissection is proceeded through there is a nerve vessel artery plate. This is the arrangement. Okay. After the superficial pyroidectomy is completed, deep lobe can be removed through the inferiorly. There is space between the branches. We can remove the inferior lobe. Okay. Radical pyroidectomy, as already told, is done in T4 lesions. Okay. Yes. Okay. So, facial paneurotic layer. Here you have seen, may have seen the thyroid. We remove the platysma like this. Okay. You can see the post-biliac digastric facial nerve. This thyroid process we can palpate. This cartilage pointer also we can palpate. So complication of thyroid is facial nerve injury. Mild injury usually happens. We can treat with steroids. Otherwise, in benign surgery, we can suture the repaired branches with proline sutures. It is a resected, or we may need to remove the nerve sometimes. In that case, in that case, anybody hearing the classes?
Yes, sir.
Yes. Okay. I thought you were unmuted and my live stream was lost. So, okay. Then we can continue. Okay. This resected nerve can be grafted with the sural nerve. Usually we use sural nerve. Okay. These are temporary facial, following the facial injury, we can lift the defect in fascia. There will be a deviation of tongue that can be lifted with temporal fascia sling. The upper eyelid can be closed with the lateral tarsorrhaphy. Okay, or you can do dynamic neurovascular, both muscle, vessel, and nerve all together grafted to the stump of the facial nerve. So another short note, Frey syndrome. The parasympathetic fibers to the parotid gland will merge with the skin or the sympathetic nerves or the parotid gland. Whenever there will be salivation, there will be sweating over this area. It is gustatory salivation. We can test with the starch. We have to paint this area with the starch initially, then keep it for dry, and then later we can paint with the iodine and ask the patient to eat something. Then when there is a secretion, it will turn blue. This is starch iodine test. Okay, we can conservatively treat with glycoperin is anti-secretory and antiperspirants like aluminum oxide. Then we can give bottle injection, and we can remove the tympanic branch of glossopharyngeal, that is Jacobson urectomy. Okay, we can prevent this by going beneath the smooth fascia, or we can opposite this temporal fascia over the defect after we remove the parotid gland. These are some practical points. How we palpate the deep lobe. Deep lobe is bimanual palpation. Okay. The parotid duct is. Vaishak, can you hear?
Yes, sir.
Yes, yes. Okay, then these are some practical points. Parotid duct is bi-digitally palpated. Just included. The topic is over. Just include. We may forget. This is lobe is bimanual and parotid duct is bi-digitally palpated. There is a superficial. When the superficial lobe is involved, we can see it as a parotid swelling. When deep lobe is involved, swelling is seen between the inside the mouth. You can see lateral wall of pharynx, posterior or the tonsils. You can see the swelling. Dumbbell sign. It's a dumbbell sign. Okay. These are some practical points. How will you examine the facial nerve? Deviation of tongue, difficulty in closure, Bell's phenomenon, taste sensations normal, because it is given inside the auditory canal. You have to look for the cervical node in parotid tumor. Then we can, I will ask some questions. Vaishak. Can you hear?
Yes, sir.
About the weight of that parotid gland. What's the weight? How many grams of weight of parotid gland? Don't worry, it is around 15 grams. Okay.
Okay.
15 grams. There are some points. Do you know the Hamilton-Bailey technique of identifying the parotid facial nerve? Should read about this. Okay. Then anybody else other than Vaishak? Anybody hearing? Can you hear? Hello. ഹരി ഉണ്ട് ഹരി ഒന്നുമില്ല എല്ലാവരും പോയോന്ന് സംശയം അതെന്താ വിളിച്ചത്. ഹരി പോയോ? അൺമ്യൂട്ടായിട്ട് നിൽക്കുന്നില്ലല്ലോ. ഇങ്ങനെ അൺമ്യൂട്ടായി നിൽക്കുന്നില്ല. അല്ല എല്ലാരും പോയോ അപ്പൊ ക്ലാസ്സിൽ ആരും കാണുന്നില്ല. അല്ല സൗണ്ട് ആതിര, can you hear? കുറച്ച് പേരൊക്കെ ഉണ്ട്. ഞാൻ കഴിഞ്ഞ കുറച്ച് ക്വസ്റ്റ്യൻസ് പ്രിപ്പയർ ചോദിക്കാൻ വിചാരിച്ചു. ആണല്ലേ. മോക്ക, in fasciovenous plane of Patty, how the neurovascular bundle is arranged? The order I will tell is nerve, vein, and artery. Okay. And then, so there is one important MCQ. What is Daphne bone cyst? Can you hear? Daphne bone cyst. Daphne bone cyst is ectopic parotid gland in mandible. Okay. ഓഫ് ചെയ്തോ. ഇത് കഴിയുന്ന എങ്ങനെ? ഓഫ് ചെയ്യുന്ന എങ്ങനെ? ക്ലോസ് ചെയ്താൽ മതി. ഓക്കെ ഓക്കെ. വെറുതെ പിടിച്ചു നോക്കുന്നത് ഏറ്റവും പുറത്ത്. Do you know about the daily salivary secretions? That is about 1000 ml. Okay. It's about 1000 ml. Okay. Lot of disturbances when we unmute the class. Okay, then we can all have this slide, and you may have exams in current this corona scenario. You may have exams on your patterns, current Kuhas pattern, maybe 1 or 2 months delay. So you need to study these topics. You can have all have this PPT, and most of the questions in parotid are covered in this PowerPoint, and facial are questions relating facial are also covered. Thank you all for participating. Okay. Okay. Any questions? Okay. Study.
Thank you, sir.
Okay.